Thank you very much for that beautiful introduction, and thank you very, very much for inviting me. Having listened to the last couple of talks, this is going to be rather different. There is a pathology slide in there somewhere for you, just to keep everybody happy. But obviously, I'm going to talk much more about precision diagnostics, but really using cardiac MRI as an exemplar, and then depending on the time, we'll see if we can do some echo as well. But if not, it's really the same kind of principles. Just for my conflicts of interest for clarity for everybody. So thinking about cardiovascular disease and cardiac MRI, I'm going to talk about where are we, and then obviously the world of AI. We've all heard a lot about AI, particularly in the last 24 hours, with apparently AI can take over the world. And thinking then about how we might go forward, and perhaps some words of caution, and why, although I think the world of AI is coming, I don't think we all need to resign and retire just yet. I think there's jobs for all of us. So for those of you not familiar with a clinical cardiac MRI scan, why did I begin my journey in cardiac MRI? This is your answer in a single slide. I show this at every presentation. Why do I do that? Because this shows the power of MRI. You can just get so many, sorry, some of these are untimed, so many different pieces of information: anatomy, function, scarring, fat, vascularity, swelling and edema, flow, and ischemia. So there's lots of different pieces of information you can get. And the key with cardiac MRI is that none of these are interlinked. These are all separate experiments. They are completely independent. So it's not like some of the other imaging tests where everything is an inference. And that to me is what makes it so powerful. So if we just think about a conventional MRI study, we would do some form of assessment of function. We would look for some scarring, and then maybe we would do some stress perfusion or some more advanced characterization with T1 and T2 mapping to look for edema. And then we'd write a report. This is just perhaps a summary. Well, what's the problem? Nothing wrong with that. Well, we're in an AI revolution, and AI is changing everything we do. It helps us order our online shopping. Taxis and Uber are just completely run by AI. But medicine, we're not quite there, and there's a lot of reasons for that. Also, as well, we need to think about these concepts of accuracy and precision. This is clearly the holy grail, to be highly accurate and precise. You may argue, and you'll see at the moment, I think we've got low accuracy and a precision in lots of the things we do try and measure. But what we don't want, and what is very easy to achieve with artificial intelligence, is to actually measure the wrong thing, but measure it very, very well. This is basically what all of you do every single day. And it's summarized in a slide. You take a patient, you acquire data that could be history, examination, investigations, treatments, etc. You make an interpretation, you make a decision, you intervene and you follow up, or you're not sure, so you do more tests, or you wait and repeat. This is what we do all day. This is medicine in a single slide. You will know far more about this than me. This is one of my more pathological slides, but here we have a normal myocyte, and here we have one that has titin in it that's clearly grossly abnormal. But here's the disconnect. This is talking about genes and genotype to phenotype, but we don't normally talk about that in clinical cardiology. So we know that there are roughly 26,000 genes with about 15,000 proteins related to myocytes, and there's 13 contractile proteins. We also know that there's a 15% chance of a cardiac phenotype if you have a genetic mutation of any one. But that's not really what we measure, is it? We probably measure the wrong things. We measure things at the end rather than the start. So we measure things like scar. That's an end stage process. We don't do it very well, and it's not disease therapy or anything very specifically linked. So we're not really doing very well. And the way I'd think about this to explain this is think about oncology. So if we were in an oncology meeting, we wouldn't just talk about someone with breast cancer or bowel cancer. You talk about breast cancer with about 5 or 6 genes afterwards, and all the therapy would be prescribed based on that genetic, that genetic sort of code, if you like, so the genes that they had. So it's very, very personalized. We don't do that in medicine. We don't say hypertension, this gene negative, that gene negative, this positive. We just go hypertension and give them ramipril. Yeah, we're not very sophisticated. We're very simple. So What does the heart do? Let's think about it. It develops, it needs to be able to work at high efficiency using low energy when it's resting, adapt to working state, and evolve, obviously, as you grow and obviously as you change. So kind of we're our own worst problem. But we keep measuring things because we keep getting new toys with which to measure them. We've got lots of new scanners. We've got scanner, 20 years ago, cardiac MR didn't exist. And we've got portable ones as well. But if you think about your definition, heart failure is not defined on anything, but it's almost a clinical definition. That's what it is. It's not a histopathological, it's not a genetic, it's just purely, clinical syndrome and have they got a reduced cardiac output. Okay, so it's based on something very clinical. Dilated cardiomyopathy, a big heart that doesn't pump with no coronary disease. Doesn't sound very, very technical to me. It's very simple. But we know that these things carry significant morbidities and mortalities. So they're important, but we define it on something you don't have. Probably time to do a bit better. We also define wall thickness as something like hypertrophy greater than 15 millimeters. That's how I would define hypertrophic cardiomyopathy. From a pathological, you might talk about myocyte hypertrophy and disarray. Okay, you could talk about mechanical ischemia, you could talk about cardiac myosin inhibitors. There's lots of ways, but we need to bring all of this together. So why? Because none of this mattered 20 years ago, because the treatment for most heart muscle diseases and most things outside coronary artery disease there wasn't really any good treatment. But now we're in the age of precision treatments that are targeted and are likely to be targeted to individual groups. We've got mavacamten, the first treatment for hypertrophic cardiomyopathy, tafamidis and others that treat cardiac amyloid. And these are very specific. You can't just give them to everybody. So we need to move away and we need better biomarkers. So we define cardiac pathology by what we can see, because that's all we had. It's not got a lot to do with biology, but it was the best we had. But we don't really do that very well. So when you look at how we measure ejection fraction, right? I mean, for me as a clinician, so much of cardiology is based on ejection fraction. And I've spent 20 years of my career telling you how wonderful cardiac MRI is and how terrible echo is at measuring cardiac function, right? I don't believe that anymore. They're both rubbish. MRI is just slightly less awful than echo, okay? If you look at the reproducibility and the variability, it's really, really high. So what we've been telling ourselves for years, we're not actually very good at, okay? So we can't even measure the simple things we want to measure that we now don't think are very good. We don't even do that properly. Similarly, this is another study, again, looking at, mugger scans versus CMR and echo. There are plenty of these studies. This is another way to think about it. Yes, MRI is better and more reproducible than echo or mugger, but it's still really, really bad. And you're basing quite often life-changing treatment decisions based on these numbers where there's a huge amount of variability. Similarly, wall thickness, we'll come back to this, but we base things based on a single measurement of 15 millimeters. Really? Is that, in the modern world, is that how we should do this? Because if you actually ask people and say, what's the wall thickness here? That's what you're going to get from 20 world experts, okay? One of them couldn't even measure it in the same place. So you get all kinds of different answers. And don't forget that wall thickness actually has clinical relevance and can have clinical connotations, sorry. But if you get a machine to do it, which is the blue, it will do it much more consistently. The question is it also accurate and precise, or is it just precision? If you remember the bullseye, are we hitting the bullseye or are we on the side? So this is just to show you again that if you get experts to measure wall thickness and try and agree with each other, they're not very good at it. But if you get a machine to do it, you can see here that you can reduce that variability quite dramatically. But it's not just in MRI, right? I mean, for every MRI scan you do here, you'll do 20 echocardiograms. That's the rough average. You can do the same thing in echo. And you can show in echo measurements of wall thickness are a bit all over the place. I won't go into this in detail, but the rough way you measure wall thickness and tell a machine to do it actually comes from neurology. What you do, in effect, is you draw a contour as per here. You set the endocardial border to 0 volts, the epicardial border to 10,000 volts, okay, or the other way around. And then what you would draw is a lot of lines around here that were the sort of same voltage, okay? So, and then from that, you can work out the best way to draw the shortest line. That's how you do it. There you are. So this is how to show you to do it. So you can see you basically, you set the edge, 0 volts, 10,000 volts, and then you draw volts, say, at 1,000 lines here, 1,000 volts here, lines at each of 1,000 volts. And from that, you can work out the best single line. It's very reproducible. Okay. This is how it looks for real in a piece of software. But as you can see, this can now be fully automated. But beyond that, you can do what I can't do. So I could probably draw each of these lines, one per slice, but what I couldn't do is do a true polar map. So this is a polar map. This is hundreds of lines drawn on that left ventricular short axis stack. Hundreds and hundreds. It would take me hours. Okay, I don't have hours. We have to live in the real world of clinical cardiology. And you can get these beautiful little maps and polar plots. And so you can see here that apical hypertrophic cardiomyopathy, you can actually see the increased wall thickness towards the apex. And it's really, really easy to see. Classic septal hypertrophic cardiomyopathy, that counterclockwise hypertrophy in the septum, very, very nice and easy to see, okay? You can see that in seconds. You don't need to look and start measuring things on here. Again, this is just the same sort of thing. So you can use these plots to try and look at different pathologies. So here's hypertrophic cardiomyopathy, very nice counterclockwise hypertrophy. And Fabry's, which can often mimic hypertrophic cardiomyopathy, but not quite looking the same, a bit more diffuse, not so much that classical pattern. Something to think about for the future. You can also plot interval change as well. So you can see here, this is somebody who ended up, this is amyloidosis, but an initial scan, normal wall thickness, and you don't need to look for more than a second to see their wall thickness has dramatically changed, and globally so, and particularly towards the base and the mid of the left ventricle, just based on the redness here, which is absent here. Okay, does anybody actually know where the definition for hypertrophic cardiomyopathy comes from? Okay, so you have to, I love old papers, okay? I'm just one of these strange guys who likes really old medical papers. You have to go back to 1973. That year is incredibly important because it's the year I was born. But apart from that, this paper was produced as well. And it describes increased thickening above 15 millimeters in, 15 subjects. Doesn't say whether they're male or female. Certainly doesn't say whether they're Caucasian or their ethnic background. Doesn't tell you how old. 15 subjects, okay? And yet we base the whole of current medicine on this study, which is as old as me, which is 53, and was based on 15 patients. And it's fine. All they had at the time was M-mode echocardiography. But really, maybe it's just time for us to move on and think about how we might refine that work and move on. So how could we do that? Well, if you could take a large population, a large healthy cohort, and compare it to a known set of patients with hypertrophic cardiomyopathy. And then what you'll do, so the way you run AI models is usually you have a test set. So you sort of train the model, then you test it to make sure it does what you think it does. And then you apply it to an abnormal population, if you like, and see what happens. And what you can see here is that if you take a bunch of normals and you sort of work on this 15 millimeters as being your sort of cutoff, is that we don't need to throw it in the bin. Okay, so we're not going to change the world. We're not going to say it's wrong. All we're going to say is that based on your age and your body surface area, you might need to do a bit of adjustment, which is probably what you do in real life anyway. Because if you had a 4'6" Indian lady who weighs 45 kilograms and she had like 19 millimeters of hypertrophy, you will be much more concerned than if it was a 6'4", huge male rugby player at 125 kilograms who had 18 or 19 millimeters of left ventricular hypertrophy. So you do it already, but we can't put that into an AI model. So we have to think of a way to put it systematically into a model and sort of systematize it. So, and it's different between men and women. That is not a surprise, perhaps. And also ethnicity as well. So you can come out with these, if you like, these more personalized formulae for wall thickness based on an AI measurement that's measured hundreds and hundreds of measurements within the left ventricle to calculate the maximal wall thickness. That's just a bit nuanced, based on 15 millimeters, plus or minus a bit based on age, sex, body surface area, etc., etc. That's all it is. Some people get very, very angry about this and say, we're trying to turn upside down the whole world of clinical cardiology. We're not. We're just taking what was great at the time and was the best they had and saying, let's bring it into the 21st century. It's the same philosophy with left ventricular function. So this, if anybody's ever done lots of cardiac MRI, I can see Anna in the audience. So, you know, Anna probably remembers this as well as I do. But literally, so you have to take serial pictures down the short axis of the left ventricle, 1 centimeter apart. You draw the contours in end systole and end diastole as shown, and then you sort of put them in an Excel spreadsheet and calculate the ejection fraction. Okay. The work on this that showed it was more reproducible than echocardiography is from well over 20 years, nearly 25 years ago. So again, it's quite old work. And from this, all these reference ranges were derived, etc. And the reason that we liked it is because we thought it would help us more accurately characterize does somebody have normal or abnormal function and thereby risk stratify them or monitor them. And it's better than echo at the time, although don't forget, nothing's static. So this is pre-3D echo, this is pre-contrast in routine practice, all those kind of things, okay? So everything gets better and everything moves forward. Okay, I was a little bit older when this was produced. This is the first paper talking about left ventricular function in cardiac MRI. It's from 1985. As you can see, again, 12, we call them patients this time. We've moved on from subjects to patients. Still don't know whether they're men or women, okay, or anything else, but, you know, okay. And they showed you could measure left ventricular function. But I think we need to move on. So we need a proper AI tool. I've been through the basics of how you train an AI model. So you kind of set it up, you have a test data set that you sort of test on it, you make sure it's functioning, train it up, train it up on your training data set, then your test data set, and then you sort of see what happens in your pathologies. This is just to show you. And there's a couple of things here. So you can draw these circles, as you see, but also you can see here it's monitoring the long axis function and incorporating that in the left ventricular model, which would take me hours and hours to do as a human being. Also drawing these circles every single frame. There's 25 of them in each cardiac cycle. This is just taking me a lot of time. A machine, once you train it, will do it very quickly for you. But be careful, okay? So you can have things, it can get fooled. So here we go down the left ventricle, all very good. And then you can see here that this person had got a breast implant and it drew around that. So then this is where you refine your model, right? So you then go back to your model, you train that out, you tell it not to do that, and then you rerun it and see what happens. And similarly here, it didn't quite know what to do here. You've got a bad image. Now, what do you want it to do? Okay, you have a choice. And this is the thing. This is why we still need people, because you could just say, right, ignore that. And instead of saying these are all 1 centimeter apart, say this slice and this slice are 15 millimeters, i.e. a centimeter and a half apart, and you can compensate and interpolate, or do you want it to try and draw the best it kind of can? There's no right answer. You just need to come up with a plan and you just need to tell it what you want it to do, okay? Clot is another one, so that causes a problem here. You probably don't want that in the mass, you probably want that in the left ventricular volume, so again, you just need to train that out. And this is also is then sort of the things that you can get. As you can see here, the level of detail and intricacy once you've trained it, particularly if you want to draw around those trabeculae, can you just imagine how long that's going to take me? I mean, I'd be here till next Christmas. So it's not going to happen, all right? So you can actually start to use it beyond the human, what a human would do. But how do you evaluate a model performance? Now, here's your problem. So I want to show this model is better than a human being. Right? But my reference point, what's my reference going to be? A bunch of human beings who measured this. So how can I show something is better than a human when my ultimate reference point is another human being? Yeah, it doesn't, do you see, it just goes right. It doesn't make any sense. So, and are humans always right? We'll come back to that because there's some interesting data. Do we actually do what we say we do? Maybe not, okay? So you can look at sort of areas of overlap and union, and we've looked at reproducibility, so putting the same set of data through multiple times and seeing if the AI will give you the same answer, okay? So you can scramble, say, 110 patients, and get them to, scan, rescan. And you can compare what a human would draw with that data scrambled up compared to a machine. It is no surprise that the machine does better. It's much more reproducible, okay? Similarly here, it's the same kind of thing. These are just a couple of studies, just to show that the machine, when you program it up, will outperform you as a human. But this is quite interesting. So when you measure ejection fraction, try as you might just to draw the circles and do nothing else. That's not what you're actually doing. What you're actually probably doing is a complex algorithm in your head based on the images you see, whether you think there's anything there, and also the rest of the history about the patient, okay? Because you will have some clinical information. It may be your patient. And so if you have a 20-year-old ballet dancer who's completely fit and well, yet her left ventricular ejection fraction comes out at 54%, you're probably going to go back and nudge the numbers to get it over 56, 57%, because it's almost certain it's normal, okay? But that's you being a human being. Machine doesn't do that. It doesn't know that. Now, ultimately, you may build out bigger AI models that incorporate all the other clinical information. We're a way off from those. Those are quite complicated. So if you compare humans and machines, this is what you get. And what you notice is the biggest areas of discrepancy are around 60% and 35%. What's interesting about those two numbers? Well, there's two things interesting. So around 60%, depending which reference range you use, is normal for LV function on cardiac MRI. And 35% obviously can be a decision treatment threshold, yeah? So exactly what I've said. When we measure it, we're incorporating that other information because we know if we put the ejection fraction below or above 35%, it fundamentally alters what happens to the patient, okay? And similarly here at 60%. But the machine can't do that because you didn't program it to do it. So it will just do the numbers. So this is why nobody has to worry about their jobs. This is why AI is going to be a really great support and adjuvant to us, but it's not going to replace anybody anytime soon. Because to make that decision, you need a doctor and you need somebody who can think about complex clinical decision making, and you need to talk in complex multi-professional teams. And that's not going anywhere. So we're all completely safe. We're just going to get better data. This is just to show you, I think, let me just, is that one going to, oh, okay, I'll just show you this one. Yeah, so this is just to show you some full quantification of data. There's another one here, I think, do that. So yeah, it's just to, okay, scarring. So this was the big forlorn hope. So when I started cardiac MR in 2001, late gadolinium enhancement had just been invented. And there was great hope for it. We could see scar directly. We could be pretend pathologists even, we could see scar. Never been able to see scar. You could infer it from lack of wall motion or sometimes speckling on the echo, but not like this. You could actually truly see it. And we started to learn that different patterns of scarring were associated with different diseases. That's just another pictograph of it. So, subendocardial or transmural scarring, infarction, patchy areas in areas of hypertrophy, particularly in the septum, would be hypertrophic cardiomyopathy, et cetera, et cetera. There's different patterns associated with different pathologies. But the thing is, it's always kind of the end process, isn't it? Scar's the end game, yeah? Once you kind of got scar, you're a bit late. What you'd want is really to be a bit before the scar. The other thing we started to learn is that no scarring pattern is really that sensitive or specific for a particular pathology. The closest is probably subendocardial scar in the pattern of a known coronary artery distribution, which is coronary artery disease, i.e. infarction. So infarction is probably one of the best we've got, and that is relatively specific and sensitive. But the others, they all get sort of overlapped. I bring up here, and we learned a lot about the diseases that, again, we just hadn't had this insight. So this is a very old study where they took 100 patients who had dilated cardiomyopathy diagnosed by other tests at the time, echoangiography. And what they showed was that about a third of them had dilated cardiomyopathy with no scarring. Some of them had this mid-wall scar, which then was subsequently shown to have an adverse prognosis. But you actually found a significant proportion of them actually had coronary artery disease or it had significant infarction, just had been misdiagnosed. We also know that heart failure is predicted by fibrosis, which makes sense because if your heart is full of scar instead of myocytes, it can't contract. We also know as well it predicts arrhythmia. But despite all of this, it's never really been quite as good as we've hoped. There's a lot of negative data out there about looking at scar and late GAD. And the reason is the technique itself. So when you look at late gadolinium enhancement, and when you look at most images on MRI, okay, they don't have Hounsfield units. So CT has Hounsfield units. So that dot on that CT scan, if it's 300 Hounsfield units, will be 300 Hounsfield units, no matter where that patient was scanned on what scanner. It's an absolute unit, okay? MRI pictures don't work like that. They're very simple. Basically, you sort of create the data, you find the brightest and the darkest spot, you set the darkest spot to 0, the brightest to 10,000, and then you kind of scale it all and make it look pretty from there. That's roughly what's happening behind the scenes that you don't get told about. So it's very good at looking at relative things, so something that's grossly abnormal compared to something else, like an infarct, where you've got a bit of normal myocardium and very abnormal scarred tissue. But it's not very good where things are diffuse, like amyloidosis, and it's not very good at getting you numbers, okay? So getting quantifiable data out of MRI pictures is actually pretty tricky. And that explains why T1 mapping, which some of you may have heard of, has very wide confidence intervals for the range of normal, because you're trying to get quantitative data out of something that isn't ultimately quantitative, yeah? We're trying to fudge it. So you have the same question with scarring. And what you can see here is the same patient. Here's their late gadolinium enhancement image. And you can see, depending on how I want to measure the scar, I measure it myself, use a technique called full width half max, or 6 standard deviations from remote normal myocardium, 5 or 2. I can get completely different numbers. This is all that, I could just pretty much make this up, okay? There is a paper that someone's going to tell me about, I'm sure, about the 15% scar in hypertrophic cardiomyopathy. But the community in CMR is scratching its head a little bit about that because it's difficult to understand quite how they did it. And in fact, I spoke to the authors and I said, how did you do this reproducibly and, and measure this scar? And they go, well, you just go for the bright bits. I was like, all right, that's really scientific, isn't it? Okay. That's what they did. But you can see the challenges here. So, but I don't know which is correct. And remember, we may have some histopathological specimens to look at to try and help us, but in the majority of patients, we don't. I can't just explant their heart. You may be able to look in some patients who get transplanted or who die soon after the scan, but that's not what happens most of the time. So we just kind of don't know. We just know there is an association. So fibrosis is a challenge. It's hard to quantify, and diffuse fibrosis on MRI is really tricky. So I would say, although there's tools like this and you can draw pretty pictures, a little bit of a work in progress and caution at the moment. Again, something for us to work on as a community. As you can see, I can just, if you look, I can just massively change by how many standard deviations, the amount of scar here, by a factor of 2 or 3. So not small, huge. Or in fact, probably even worse than the reproducibility of function that I showed you earlier on. So this is even worse. Right, stress. So the last bit we showed was stress imaging. So this is to look for ischemia. So stress the patient with some kind of, usually a vasodilator stress in MRI. So adenosine, regadenoson or dipyridamole. You look for areas that are hypoperfused compared to normal, and you have a stress and arrest scan for comparison. So basically, again, it's very visual, okay? You saw at the start, you just look at some pictures and you look for the gap. So how are we going to get some numbers out of this? It's a little bit more tricky, but obviously you can plot the contrast as it goes through the myocardium over time, because as you saw, you see the contrast go through. So you can start plotting that, and from that you can start to then look at those curves, and then you can make a map, okay? And once you've got a map, you can start using AI, okay? So once you've got numbers and maps and curves, you can start doing stuff with it. So what you can do here is actually start to measure perfusion and an absolute quantification of perfusion. So you can see here during stress, high perfusion, and rest, lower perfusion, which would make sense in this normal patient. Okay, and here you can see somebody who's got quite marked coronary disease here in the right coronary artery, probably the circumflex, but actually has quite abnormal perfusion, full stop, compared to the normal, again, that I just showed you. But not just coronary artery disease causes ischemia. We know the cardiomyopathies do as well. You can see that here in this patient with hypertrophic cardiomyopathy, a really marked perfusion defect in the septum here. And yeah, it's clear on here, but it's even more clear how profound it is if you have true perfusion quantification and you have a perfusion map. Okay, and then now you're sort of, and then if you start looking at perfusion in hypertrophic cardiomyopathy, you find that in a significant proportion of patients, they get perfusion defects and they get that prior to starting to get the scar. Why would we have cared about that 10 years ago? Well, we wouldn't. Why might we care about that now? Because we have treatments and there's more coming. And it's too early and we don't know, but maybe some of those treatments would help before you got the scar, and actually you'll never get the scar anyway. Okay, and then this is, so apical hypertrophic cardiomyopathy, it seems that in apical hypertrophic cardiomyopathy, this is a single study, but it was almost 100% of patients with apical hypertrophic cardiomyopathy have apical ischemia, even if they don't have any late GAD. So again, suggesting particularly in this variant that actually this might predate the scarring. And with maps, as you can see, it's pretty easy to see. Yeah, you don't need much training to realize that the perfusion is abnormal here in the blue bit. This is just to show you again. This is very, very early, but somebody on mavacamten, so one of those new treatments, and you can see literally with 8 weeks how the ischemia has gone away. Their perfusion has improved dramatically. And that's why personalized treatments and earlier and more precise and accurate diagnosis is hopefully going to move everything forward for us. Because if this is actually true, and this is anecdote, this is one patient, but if this is true, and this puts the perfusion back to normal and stops that process and stops the scarring, this is really quite a significant shift in the pathophysiology of hypertrophic cardiomyopathy. But it's too early, but it's food for thought. Talked about that. This is just to show you, I'll just let it run quickly. So just to show you how quickly now you could do everything just for, so these tools are actually pretty fast to do all this analysis for you. 3 minutes. All right, with 4, shall we? Okay, I've bargained on 4 with the boss. Okay. So just something else. So, but there's new things coming along. There's something called diffusion tensor imaging. So myocytes are arranged in sheets, as you know, and they slide over each other. Diffusion tensor imaging is really complex, but it looks at abnormalities in the way the sheets slide over each other, okay, which is grossly abnormal in hypertrophic cardiomyopathy. This takes about an hour per patient to do, plus several hours of post-processing analysis. It's not ready for clinical use, but looking at some of that mavacamten stuff and perfusion imaging, you can see how this might start to become relevant. So what you're going to have, I think, ultimately, is, as you can see here, this is quite a nice diagram. You've got measurements of fibrosis, structure and function, other data that you put in from your clinical scenario. And this is where I think AI really can help us, because it can help us quantify, okay, and systematize a lot of these inputs so that when we put them into a bigger AI model, trying to put everything together, it might actually make some sense. Because if we're putting data in that we know is highly variable into the model before we start, why would we be surprised when the model doesn't work? It's not going to work. So this is quite important, because this is, I think, where this is coming. Just quickly to say, in 1 minute, it's not only CMR, but echo is exactly the same as I said, okay? So we know that echo using AI will improve precision. It's a bigger study here. It's called the WAY study, but just quickly to show that. And obviously echo is quicker, quicker, more convenient. There's more of it done, etc. And also as well, that will help particularly in echo, where you're much more likely to do serial studies using echo than CMR, so you can track changes over time. So particularly if you have 2 or 3 scans and you want to see if there's any change in function, say with a patient on cancer therapy, on chemotherapy, it's much easier for you to do it. So bang on time as promised. So this is my final slide. So I've sort of taken this, which is a lot of pretty pictures, which is what we currently have. And I've talked to Hope a little bit about not how we should be scared of AI, but that it's coming. But we should actually embrace it, because we're going to learn a lot more about how to analyze these. We're going to be much better doctors. We're going to be supported and facilitated, but we're all still going to be here, and we're just going to have to work slightly differently with much higher quality data. And on that, thank you very much for your time.